afternoon to you all. I am Dr. Kiran, working as a radiation oncologist in YASHODA Hospital, Hyderabad, India, which is southern part of India, and heading the department. Today I was asked to talk about breast delineations, which are the basic things which we need to know before starting contouring, and the various contouring guidelines and the controversies surrounding these delineations. And before that, a brief of our department at YASHODA Hospital, Hyderabad. This is the building where right now I'm sitting. We have 4 linacs and treating to 250 to 300 patients per day. And we started the department in 2004 with dynamic IMRT. Later on, we were the first in Asia to start the rapid DAC. And so far, we have treated more than 16,000 patients on rapid DAC. And rapid arc based SPRT was started in 2010, and we incorporated the 3D compass dosimetry in 2010. Later on, we started treating in 2011 the gated rapid arc for chest and the liver tumors. And in 2014, it is triple F beam, and we are expecting MR LINAC in 2021. This was we are the first in Asia to start the rapid arc, which is well covered in national media in India. And we are pioneers in treating patients with rapid arc, and this is a letter of appreciation, and this is courtesy taken from the Varian website. As of now, we have treated more than 16,000 patients with rapid arc. And we had a good understanding and a memorandum of understanding with the Varian medical systems. What we do is that we are the training institute for the Varian end users in regarding the IMRT and the rapid arc clinical school. We usually conduct it 5 days a week, for 5 days for 4 times a year. So far, we have trained 264 radiation oncologists and medical physicists, successfully conducted 32 Varian medical schools as of now. This is only intended for those who come through the Varian school, Varian end users. We had an international radiation oncology project. It's a pilot project where the YASHODA Hospital and National Cancer Institute at Jakarta, and it was in the 2018 when our physicists, the clinicians, and the technologists visited there. We helped them starting the commissioning their mission, and also the physicist was trained in planning. And the first case was taken in nasopharynx for IMRT in Feb 2018, and for parotid by rapid arc in Feb 2018. And this is a letter of appreciation given by the Ministry of Health of Indonesia towards us for helping them to start their the rapid arc. We have research collaborations with international universities like Institute of Oncology Research with Switzerland and the Denmark, VU University, and AMP, and Varian Medical Systems with the US, and also with IBA with Germany. We have 46 international publications in various journals from our institute. And now today I was asked to talk about the breast delineation. What we, next in half an hour, what we see is like, we'll see the importance of radiations. So it is a gold standard and in the treatment of breast cancer. We also would see why we need to contour and what are the various contouring guidelines like RT-Version and EORTC, and what are the controversies surrounding this RT-Version and EORTC, and at the end. So this was early breast cancer trialist collaborative group. This was the meta-analysis, and the same slide was shown by the previous presenter too. And the impact of radiation on the breast conservation, like the first recurrence, and this is breast cancer mortality rate. The upper side, you can see that with radiation, definitely the separation is more. This is for N-positive disease, and if you see the survival, definitely with RT, it added to some extent the survival benefit. And if it's for post-MRM with the regional nodal irradiation, S, this is for first recurrence, and this is for breast cancer mortality. N0 is for the upper chart, and node-positive disease for the lower one, and you can see how the two lines are separated. And impact of radiation, this is also from the similar meta-analysis of 1 to 3 node-positive disease. And it was published, it was in ASCO 2016 that it was where 1 to 3 lymph nodes can be considered for a regional nodal irradiation, like the chest wall irradiation, I'm sorry. So This is for the first local recurrence, the first recurrence site, and this is for overall survival. The breast cancer mortality rate, definitely if you see adding radiation would help for better local control and to some extent increase the overall survival. And as per this meta-analysis, there is 9% improvement in the overall survival at 10 years. The results of the Supremo trial are awaited. The projected estimated is 10 to 20% of local control. This is usually the inclusion criteria is 1 to 3 nodes and T2 with other risk factors and multifocal and large tumors which are greater than 2 centimeters. So results are awaited, but the projected is 10 to 20% local controls would be definitely more compared with that of no radiation in this set of patients. The impact of radiation on intramammary nodes, we have MA220 trial where the disease-free survival was 82% versus 77% without irradiation to intramammary nodes. And the EVO-RTC trial, where 4,000 patients have been treated with the central and the medial tumors, the 10-year disease-free survival was 3 to 5%, and there is a trend towards increase in overall survival. This is a prospect to Danish intramammary node study. Compare the left supraclavicular fossa with that of right intramammary and the supraclavicular fossa along with the chest wall. It was observed that the 3.7% overall survival in these patients, particularly with the N2 patients and those with N1 and the medial and central quadrant tumors. So radiation is the gold standard, even for patients with N1 to 1 to 3 nodes positive can be considered as per this data. Why we need to do the contouring? Like now we are moving from 2D to 3D and 3D to IMRT and later on from IMRT to protons. So as you all know that better conformity, there will be less side effects. Hence, we need to accurately delineate the clinical target volumes before proceed for planning. This is a gold standard treatment field for supraclavicular. You only come to know why I said it's a gold standard. As we know that the borders, this is what we have been practicing all these days, like the medial, ipsilateral edges of the vertebral bodies, laterally, some take it as the medial two-third or others take it as lateral to the second rib. Cranially, it is 3 centimeters and caudally it is matching with the tangential fields. And if you want to treat with the axilla, what we do is we drag off the lateral field and keep the lateral part of the femoral head and thereby shielding this one. So, and the matching 5 to 7 degree couch twist is required, or we can use an off beam block or a 5mm spacing on the skin. What we practice is like 40 gray, the start trial or the Canadian trial, like, to the 90% using the 6 or 10 MVV. But if the separation, the medial tangential and the lateral tangential is less than 17 centimeters, we usually use 6. But if it is greater than 17, the 10 MV would do better. But we have only 15 and 6 and 15 MV, so use for our patient 6 MV. The posterior boost, yes, if the separation is greater than ABP separation of the neck field is greater than 15 centimeters, we give a posterior boost field, and the prescription is 3 centimeters depth, and the dose is 14, 15, and the ratio is 10:1, and the 10:1. Like 4 gray goes from the post-PA field, and 36 gray goes from the AP field. Now we look into the expert consensus guidelines like RTOG. We usually follow RTOG guidelines, though it has its own side effects and drawbacks that we'll come to know at the end of this presentation. Guidelines like usually present the best available evidence. So the guidelines will tell you the evidence, but always guidelines recommendation will not necessarily result the best outcome. So guidelines can never replace the clinical expertise. They rather help us to focus the decision making, and guidelines are not mandate and they cannot challenge in the court of law. So why I said these points, you will be coming to know at the end of my presentation. So structures to be delineated, basically we need to delineate the normal structures, though these are all the normal structure, not VARs. Brachial plexus and lungs, heart, spinal cord, esophagus. We usually draw the first and the fourth rib so that it would be easy for us to contour the intramammary nodes. The pectoral major, pectoral minor, if we can draw, it would be easy for us to come to the level axillary nodes, the subscapular, latissimus dorsi, and scalene anterior intermediate muscle. This is a small video, and this is like this is pectoralis major. This is a deltoid. As we go down. At the level of C5, it's a spinal cord. This scalene anterior, intermediate, we take a 5 mm brush. Where the neural foramen is there, we take a 5 mm brush, go to the space between these two scalene muscles, anterior, intermediate. And as we come down, where there is no neural foramen, we need to draw the space between between the two scalene muscle. This pectoralis major, pectoralis minor. It's a major, minor, and subscapularis, latissimus dorsi. And this is the first rib. And we usually draw the fourth rib also for that the contouring would be very easy where to end the intermammary nodes. This is intermammary nodes. Bilaterally onto the normal lungs. As we come down at the bifurcation of the pulmonary trunk, we start contouring the heart up to the apex. So the chest wall contours, it is slightly different from the with the post BCS and the post MRM. The superior border. The superior border is like 1 centimeter above. The inferior border is 1 centimeter below the intact disease of the contralateral breast. The medial line is midline. The laterally 1 centimeter lateral. What all we need to remember or important is that the posterior border, if it is a BCS, if it is a stage 1, stage 2, what they do is they exclude the pectoralis major and the ribs. But if it is beyond stage 3, for a breast conservative surgery, the RTOG guidelines say that we need to include the breast and also the chest wall. In case of MRM, the posterior border is usually placed, complete chest wall is included. And now we see what EORTC has to say. The cranially is similarly same. The second rib, the caudally is also same. The medial lead is up to the midline of sternum. The lateral breast fold. The posteriorly, for all patients, they exclude the pectoralis major and the pectoralis major muscle, and they won't include the chest wall. But if it is clinically, if it's a T4A or T4C, only in that situation where the pectorals have been, the dorsal fascia has been involved, in that cases only they include the pectoralis major, but they don't include the chest wall. So there is a discrepancy between the posterior border when we compare with the estro fields and that of RTOG fields. So RTOG, by default of post-MRM, they include the complete chest wall, including the pectoralis major and pectoralis minor, and that of estro, they don't do that, unless it is involved. So is there an evidence now that due to this discrepancy, whether to use an RTOG or estro is still controversial? So this is a publication from the Pittsburgh University, published in 2015 in Red Journal. The RTOG chest wall contouring guidelines for post-mastectomy radiotherapy. Is it evidence-based? So just we'll go through this article, what they need to say. This is an institutional-based study. Like they have collected all the data of the patient they have treated, and the mapping was done on the chest wall to see where was the recurrence. So as per their, like from the MD Anderson MS cases in New York, what they found was that in 28% of the patient, the recurrence occurred in the pectoralis major or below the pectoralis minor to the chest wall. If you see the one more study, Brian, where it has shown that 25% of the patients had recurrence in the pectoralis major and anterior to the pectoralis major muscle. So as per the estro, if you are really contouring the chest wall or the intact disease anterior to the pectoralis major muscle, then there is a chance that as per these two studies, the chest wall recurrence might be more compared with that of those patients who are being treated with the RTOG. So it is a decision of the clinician to take, and there is no uniform consensus on this one. So the clinician which has to decide which one to follow. So the second most common site of recurrence was the muscular recurrence within the pectoralis major. So what are the, due to this variation in keeping the posterior CTV in case of estro and in the RTOG, the drawback is that because we are keeping the posterior border in the RTOG to the involving the complete chest wall, there is a significant increase in the mean heart 10 gray, mean 10 gray increases from 3 to 4%, and that of lung V20 increases 4 to 11%. So when compared with the estro one, so it is so. This is one more article published in Astro. The lack of consensus of international contouring guidelines for the dorsal border of the chest wall CTV. What is the impact of organ at risk? This was from Virginia, West Virginia, published in 2000. The recent last year publication in 2009. They just wanted to see the OIR dose and also the chest wall local recurrence. This is also institutional study. This is the estro CTV, which is in front of the pectoralis major, and the institutional variant, depending upon the posterior border, usually it is placed anterior to the chest wall, and RTOG says that the posterior border should be in the posterior to the chest wall. So if you see the recurrences pattern, the anterior to the pectoralis major is 67.7%, and if you see from the anterior to the pectoralis muscle, it is 23.5%, and if you see in between the pectoralis major and minor, it is 11.8%, and if you see the chest wall, it is 0. So the conclusion is that the chest wall recurrences are unlikely, and if it is reasonable to include the pectoralis major and minor muscle in the CT, would be a rather can be considered if the clinicians really want to do so. And they have compared the cardiac doses. This is a heart V30, V25, and V15. And if you see the doses, like it's always more for the RTOG. This is for estro, and this is for the institutional variant. And if you see the cardiac mean dose, heart and left anterior descending, it's always more for the RTOG because we are irradiating more tissue, normal tissue. Similarly, the lung radiation dose, V20, V10, V15, the similar finding, and the contralateral breast is more because we need to include the whole chest wall, and the beam medial tangent will come from the opposite breast. As a result, the contralateral breast will get more dose. So isolated, the conclusion of this article is that isolated recurrence deep to the pectoralis and are uncommon, and routine inclusion of the ribs and intercostal muscles in the chest wall CTV might not be necessary for routine clinical application of post-mastectomy radiotherapy. By including the ribs and intercostal space in the CTV, the normal heart and lung would get more dose. So the controversy is that whether to keep the posterior border anterior to the chest wall or anterior to the pectoralis muscle as in estro, or it is or complete chest wall as in RTOG. It all depends upon the clinician choice, but there is no uniform consensus guidelines. The next is like the patient was subjected to surgery, how to treat in case of breast conservative surgery. What we need to consider is that include the seroma cavity, include all the surgical clips which have been placed. We need to use the preoperative imaging. We need to take into consideration the pre-op and post-op findings, and any planning CT architectural change needs to be considered while drawing for the CTV lumpectomy site. Usually, we give a margin of 1.5 centimeters all around, and excluding the pectoralis major and cropping 5 mm from the skin. To this PTV, a 1 centimeter margin is given, taking into account the respiratory motion of the chest wall movement. Now, how to treat a patient if the post mastectomy where immediate reconstruction has been done? So for those patients where the reconstruction has been done at the later stage, there is no, like, probably the patient might have completed the whole course of adjuvant therapy. But if the patient has undergone immediate implants at the time of surgery, how to treat? RTOG is very clear. Always keep the posterior border at the chest wall. So we include whole post-operative bed and keep the posterior border at including the chest wall. What ESTRO says is that it has given some guidelines for the target volume delineation setting the post-mastectomy radiotherapy after implant-based immediate reconstruction for early breast cancer. So there are three types of reconstruction. Like, this is the pectoralis major muscle, and the whole implant is placed behind this one. So we call it the retropectoral with full coverage of the pectoralis muscle, this whole coverage. The second variant, where if part of the dorsal fascia of the pectoralis, if it is involved, then they do it as a retropectoral. That is a surgeon choice, with a partial coverage of the pectoralis major muscle and supporting material at the lower down. And the third is prepectoral. It's completely placed anterior to the pectoralis muscle. So these are three types of variants where an implant surgery can be done. So previously we have seen that the ESTRO keeps the posterior border anterior to the pectoralis major muscle. So if it is a completely retropectoral, the CTV ventral is like only the subcutaneous lymphatic plexus has to be covered. So this is the CTV where in front of this implant, this is the volume which we need to treat as per the ESTRO guidelines. And it's retropectoral with partial coverage. So in this, like, the CTV ventral is one which we need to cover the whole thing. Because the major has been removed at the dorsal side, this is the blue line which indicates that the CTV dorsal. You can see in the coronal and sagittal view where to whatever extent it has been removed, we need to cover this CTV along with this, the ventral CTV in the clinical target volume. But if it is...
finish by 5 minutes.
Yeah, in this prepectoral, we need to include the whole like whatever is the anterior to the pectoralis major, and the anatomy, level 1, level 2, level 3, as we see, like the supraclav, which is extending from the cricoid down to the sternoclavicular joint. It is around the sternocleidomastoid muscle anteriorly, posterior the posterior border, laterally the posterior border, the posterior is the anterior to the scaly muscle, and so for axillary level 1 nodes, it's a point where the axillary vessels process the pectoralis minor muscle, and from there down to the inserts of the pectoralis major muscle, and laterally it's the medial border of the latissimus dorsi muscle. And I just want to skip all these things. It's level 2 we are mainly concerned with the pectoralis minor muscle, where the axillary vessel process from medial to lateral border only, and the lower body is up to the where the pectoralis minor is inserted. And level 3, it is just from the inserts of the pectoralis minor, the cricoid, the medially the inlet, and the ventrally it is the pectoralis major muscle. Intramammary nodes, we need to contour the intramammary vessels from the upper bottom of the clavicle, the first strip to the fourth one. Upper bottom of the fourth one. The ESTRO guidelines is mostly volume based, and like we need to know the anatomy, like superior vena cava. We need to really differentiate on the CTV axillaris so that it would be easy for us to draw. And this is how the anatomy would be, like the carotid and the left subclavian, which usually it runs into the left axillary. And the level nodes, the lymph node 4 is not called as supraclavicular. All we need to do is we need to identify the This is a subclavian, which usually runs into the axillary. We need to go 5 mm up and the 5 mm down. It's anteriorly we have a sternocleidomastoid muscle. We exclude the carotids and we include the subclavian, and this will be the level 4, and this is how it is. And level 3 is the one which is the upper body is almost the same for both level 3 and 4. We include ventrally it is the pectoralis major. It is continuous at the level 2, and inferiorly medially it would be the level 4. Axillary level 2 it starts at 5 mm above the axillary vein, and caudally at the insertion of the pectoralis minor, and we need to contour the space like the pectoralis minor, anterior border. This would be the medial border, lateral border, and medially it would be the chest wall. Level 1 usually starts, the level 1 superior border of the cranial body is almost similar to the level 2, and it would up to the insertion of the pectoralis major muscle. This is the latissimus dorsi, subscapular, so imaginary line drawing from the anterior border, the medial border, the anterior border, the pectoralis major muscle. Intramammary is almost similar to that one. The intrapectoral is the groove between these two, the pectoralis major and pectoralis minor. There are a lot of so there is again the discrepancy between the EORTC and that of RTOG. Now there is enough publications where it is published from the MSKCC in New York in the 2018. So what they have seen is that they have the institution study. They have taken the data of the patients treated with the curative intent and mapped on their slides on these images. So this is the green one is the one which is local recurrence seen within the estro, and the yellow ones is the one which the local recurrence but within the RTOG. So the reason why is that RTOG keeps the posterior more includes the complete chest wall. If you see the nodal recurrence of intramammary and axillary is almost same because the continuum volumes are almost same with the astro and estro. But if you see the supraclav is very small. The volumes are very conservative in case of estro, and these red lines are the one which there is a nodal recurrence outside even the RTOG. This is where like the posterior and the lateral group of supraclav node. Just want to skip all those things. And so what the MSKC said that probably you can consider the volumes like this, though it is not well used by all, but they postulated a theory like this so that they can include all those volumes. And in conclusion, the lateral and the posterior series are not routinely contoured. That's what grade 3 breast cancer and LVSA were most commonly associated with nodal recurrence. Modifying the CTB to encompass the lateral and the posterior CV in patients with breast cancer patients with these features might be justified if clinically needed. This is one more publication in 2019, the distribution of the local regional breast cancer recurrence in relation to the postoperative radiation field and the biological subtypes. These results are almost similar to that of the previous MSKCC study, where the lateral and the posterior supraclavicular field is the area where there is chance of more local recurrence, and we don't even continue RTOG or estro. The future direction, one of the study going on, RADCOM, the Radiotherapy Comparative Effectiveness Consortium Pragmatic Randomized Trial, they are comparing with proton versus a photon, and this was developed by RADCOM Breast Atlas Committee. It's only used for RTOG 3509 and 3510 studies. What they have done is that they have included all the fat spaces between the posterior. They have completely included the trapezius muscle, whatever the medial to that one is included this supraclav. And if you come down, they have included all the spaces without leaving anything. Probably it might take very long time for the results to come out. Thank you, sir.